Okay. Good morning to everybody, and good afternoon or good evening to the other side of the world, to our friends online. We have a lot of people online. Good afternoon there. And so we start this session this morning talking about psychedelics treatments. So we this morning, please silence, okay. This morning we are going to talk about psychedelic treatment with Martell and Francesco Castellet y Ballarà. In the afternoon we have this video session, another theoretical part, and the video session with Jeffrey Goes. Tomorrow morning we have the clinical session chaired by Heribert Blas, where we are going to talk about clinical in psychoanalysis. Okay, so yesterday we talked about affective consciousness. Thank you, Max Holmes, for your really interesting support and the really interesting topic. And today we start talking about psychedelic treatment, and we have a lot of doubts because this is a really new challenge for us as psychoanalysts, as psychotherapists, as psychiatrists. So are we sure the psychedelics could be supportive, could be, no? The psychotherapy? We don't know. We have a lot of questions. Please, my slides. We have a lot of questions, and we hope that our speakers can give us more answers about this new challenge. Okay, we try. At least we try. I give you just 5 minutes of introduction. Okay. No? Okay. The first one. Okay. The first one. Inscribed on the pronaos of Apollo's temple in Delphi, we have this inscription, know yourself. No, it's too slow there. Know yourself. And the same originally was inscribed on the Sibyl's room. There is this sort of longer inscription, and they said that if you don't need to find within yourself that which you are looking for, you shall not find it outside either. If something is not inside you, you cannot find it outside. So, Know Thyself, according to me, is an invitation to go deeper into who you are, and as Oceanus said to Prometheus, know your limits, know your place. You cannot face the gods. You are not the god. So know your limits, know yourself, and know your place. And psychoanalysis, I think, is one of the most complete, not the most complete model for understanding the human psyche. IPD, Italian Psychoanalytic Dialogue, through Rome Conference every year, opens it up to theoretical new innovation, new concepts, new perspective, new challenges, asking for new answers, sometimes to old questions. Know thyself, know your limits, know your place. It's an invitation that involves the individuals as well as the therapeutic models, not only the individuals. We need to think about our models. Because knowing one's limits is necessary both to initiate new exploration, but also not to initiate actions that lead to defeat. This is know your limits. This is know your place. Last year, talking about sexuality, I said that when you don't have the answers, then you have to change the questions. We were talking about sexuality. Today I say that even if the questions are valid, such as to say about the limits of the treatment, but sometimes nothing change in treatment, nothing change. So then you have to look for other answers, not to change the questions, to look for other answers, new answers. As research in psychedelics assisted psychotherapy regains momentum, along with legislation that would decriminalize its use, it is becoming important, we think, to understand what psychedelic drugs do. What psychedelics drugs do. This is a common path, okay? Is a common stream of procedures and questions present in any psychoanalytic, in any psychotherapeutic treatment when facing new events of internal or external reality. We face sometimes new hard rock, resistance, psychosis, acting. So when we face these events, usually we think, we ask ourselves, what happens to the ego, to the self, depending on the model? And this event, does it change defenses, or interaction maybe changes? And in case we ask ourselves, does it change fit to psychotherapy? We keep going on with our patients in treatment, and as a psychoanalyst, we think it's possible the working through, or we are stop here the treatment. And in case of resistance to or resistance in treatment, usually we have our psychoanalytic tools. The play between conscious and unconscious, we know very well this play, so we can face the resistance in treatment. And when we cannot face this resistance, we ask our psychiatrist, our medical doctor, for a little help with drug treatment. And what if the tools, the drug treatment do not work? We're running in circle. We're running in circle with our patients, and the treatment it becomes longer. Okay, so stop running in circle and let's change the answer. But I think all of us here have the same concerns. I guess my thought today is the same of you. Is psychedelic-assisted psychotherapy the answer? Are we sure? Or, first concern, is it a form of healing, we think? And the answer is, it can become self-care. Or maybe, is it a form of addiction? Or it can become addiction. We are going to see this, to talk about this in the clinical case on Sunday. And another concern, thank you to Martell, I took this by your slides. Psychedelics always assist psychotherapy, are we sure? And if the effects is said, or is going to say, if the effects must be ascribed to the drug itself and not to the psychotherapy, let us say simple, it says psilocybin treatment. We don't need to call this psychedelic-assisted psychotherapy. It's a psilocybin treatment. So, I conclude here. Questions for you, Martell, for you, Castellet, and for Gus. If psychedelics are so effective in clinical practice, their use should be supported by a specific training, and which one? First. Second, what are the risk benefits of their use in clinical practice? And the last one, I'm not sure about this, but I put on the table this. Without a personal exploration during one's own analysis or during our training, of the altered states of the mind, are we sure that we can carry out this kind of treatment? Are we sure we can, individuals, or one of us, can carry out this kind of treatment? I'm not sure. So, in any case, you can email me to InfoDialogues, your name, at the end of, not during the conference, please, at the end of the conference, if you want to set a local group, interregional group, international group, you can write me and I will try to put all of you together, so maybe we can pioneering this topic. Thank you, and we start with Rome Conference.
Mi devi presentare? È molto lento però. Che facciamo?
Vieni a seguire lì, perché lì è troppo lento. Ok, the bio of, no, not you, for first, ok. Io pensavo lui.
Fa una cosa corta.
Yes, Castellet. Ok. No, te ti conosco. Cioè, I said, I'm not going to read this presentation, so please, you can. Francesco Castellet y Ballarà is the co-founder, co-chair of Italian Psychoanalytic Dialogues, and is a psychiatrist, a neurologist, is a psychoanalyst for the Italian Society, from the IPA. Is a lot of things. Is above all is going to talk. Is going to talk about the treatment, the drugs, how this work, in which model we can including this sort of treatment of the drug itself. And so I give you the speech because it's late, okay?
Yeah, it's late. My slides, please. So, good morning, everybody. My presentation will be a bit theoretical, of course, even though these theories are data-driven, and that should be, in my opinion, the standard for any future presentation. Also in psychoanalysis, there's a big questions. I was talking yesterday night with a group of people, including Mark Solms, and I was reminded to the others about the motto of the Royal Society, that is actually in Latin and is, I'm sorry, I'm trying to remember it, is about nullius in verba. That means that it is not acceptable in a scientific discussion to take for granted what the masters said. They need to provide data and to confront with experimental situation and to confront with the experience of the other based on data. That should be, in my opinion, the standard. So I start the presentation. I will be a little bit difficult. Okay. So this is actually a painting in periphery of Rome. Of course, you can spot some mushrooms up there, for example. Okay. And well, some statement to start. This from a neuroscience, actually a biophysics from Barcelona, that state that body and mind are distinguishable but inseparable. And also Mike J., that is a famous writer about psychedelics, in the last book he wrote, that is Psychonauts, that I really suggest to read. He said that the language of pharmacy and introspection may be mutually incomprehensible, but the full account of a drug and its psychoactive effects requires them both. Therefore, in my opinion, the integration of psychopharmacology with psychotherapy is the future and the unavoidable outcome of mind-body assumption in neuroscience. As we know, already talked a little bit about it yesterday, even, for example, at dinner, no? The Homo sapiens definitely loves psychoactive plants, but not only Homo sapiens, but many animals. And for example, it's quite known that elephants loves to eat some barks of some kind of trees when they start to produce alcohol, for example, and they get drunk as well. And the history of the use of psychoactive substances is incredibly far in the past. You can spot some, some of how old are they, for example. And of course, to take a more general picture about the use of psychedelics, we have to take into account the different cultures that actually frame, I will say, this use of these drugs. Of course, today we will address especially the Western scientific activity about psychedelics, but there is a general psychedelic culture, mostly underground, after the famous ban of the 70s. More interesting could be the neo-shamanism and the vegetalismo, that is a kind of church based on the use of ayahuasca in particular. And this extremely, of course, is a derivation or a modern form of spiritual and religious tradition that go back in time. Vegetalismo, as I was saying, is based on the assumption that the vegetables and plant of the region might actually has the power of cure, and the ingestion of hallucinogen and emetic blue ayahuasca is one of the most popular, especially in South America, Brazil, and so on. Neo-shamanism, in my opinion, is closer to us to a certain extent, also because we have tradition of shamans, for example, in Siberia, and the use of magic mushrooms, in sense, is really very spread all over the world. And I like to quote this short sentence from Carlos Castaneda that has been famous, very famous for my generation at least. In the 1973, he said, this is the Journey to Ixtlan, the book, the third one, if I remember well, of his Syria. And he stated, for a sorceress, the world of everyday life is not real or out there, as we believe it is. For a sorcerer, reality, or the world we all know, is only a description that has been pounded into me from the moment I was born. And the picture I've chosen is from Milo Manara, and it's a very famous comics, let's say, was written together with Federico Fellini, that after having known and read many of the books of Castaneda, had the plan of put up a film about this. But at a certain point, it's a very interesting story, but at a certain point, after several, I would say, advice from the unknown, he decided to quit it. He was very kind, let's say, of mystic kind of art director. And so we could say that mind-altering behaviors together with mind-altering drugs are, I would say, not only linked to psychedelics. And my assumption is that social brains interacting, that means culture, actually has the ability, of course, of altering our mental states. These are some examples, of course, not a complete list. And I would like to especially focus on meditation hypnosis, because we know the studies correlating meditation alteration in the brain function are quite similar to the one produced by psychedelics. For example, storytelling has to do for the power of language. That is something that we use with our talking therapy. So mind-altering drugs is linked definitely to culture and subcultures that choose their own elective substances. as you know very well, coffee, tea, chocolate, all of them can produce even very strong dependence, also having a strong effect on our behavior. And also, as I was saying before, of course, in psychoanalysis, this is a beautiful review, in a certain sense, of Rundel in the 2022. She listed, actually, I would say, authors that terrorized this altered state of awareness, in this sense, more precisely, starting from Bloyer and Freud, and I would say ending with Groth, basic perinatal matrices. That he is an author that linked very well psychoanalysis with psychedelic experience. Before talking about psychedelics, I think is useful because it's from a chronological point of view. In the Western tradition, in the Western history, actually the first experiment and experimentation of alteration of the state of mind started with the use of anesthetics, especially nitrous oxide, that was in the middle of 19th century, also called accelerant gas, and then ether and chloroform. And now we have the ketamine, the dissociative psychedelics. And it's interesting because we could start to think about the intriguing relation between analgesia and euphoria. The picture is from the famous author of the War of the Two Worlds, something like that. That's the novel, famous Wells, that wrote also a short story of a chloroform-induced psychedelic trip, like that depicted in the picture. Okay, going further into, let's say, pharmacology a little bit, that this drug wheel is very interesting for one reason in particular, because as is written, the outer rings is the established psychoactive substances divided according to their effect and pharmacological characteristics, and the inner ring is the newer psychoactive substances, because what is maybe less known is the amount of work, legal and illegal, that is actually going on in all the world to find new psychoactive substances. There is a black market that is incredibly huge, that of course get a lot of money from all the illegal market and dependency that many of these substances induce. In our presentation, of course, we talk about psychedelics mostly, and it's interesting also to note that the MDA and ketamine are not really psychedelics, but they share the same effect on our mind. So we can divide the psychedelics, as I was saying, into classes, classic and non-classic. And the term psychedelics is used only to refer to serotonergic hallucinogen, and sometimes used for a much broader range of drugs, like the empathogen and entheogen, that is the MDMA, and dissociatives like ketalar or ketamine. Of course, the atypical hallucinogens are much more widespread, and I will talk a little bit more in detail about them, because of course of the multiple data I could offer, I decided to focus on the receptors. I will say that the switch in which this substance has the effect on the neurons. And please note how the MDA has multiple effects on several receptors, this one, including oxytocin, that could explain why these drugs, also called ecstasies, is an empathogen in this sense, because we know from the study of the relationship with the mind of the mother and the child that the oxytocin is extremely important for bonding. And yes, and then also the fact that there are multiple receptors activated by this substance. Ketamine is more linked to the glutamate system, ibogaine multiple neurotransmitters as well, and scopolamine, acetylcholine that is linked to the memory system. That's why scopolamine could affect memories, and so on. Kappa opioid, GABA, and so on. There are a lot of things to say about these non-classic psychedelics. I will quote or refer only to Amanita muscaria, because there is a theory, ethnological theory, in which these are the typical color of Santa Claus, and probably the tradition of Santa Claus is linked to the use of these substances as well. Interesting, eh? And by the way, there is another proof, I will say, that is the deer of Santa Claus are extremely fond with these fungi or mushrooms. And of course, seeing the deers flying is of course an hallucinogenic effect of this substance, okay? And now we are the classic psychedelics, defined exactly for the binding with this receptor. As before, I've chosen only to focus on the medium effect in time, how long this affects the brain. The ingestion of this LSD, for example, is about 12 hours. Psilocybin, 5 to 6 hours. The ayahuasca or the methyltryptamine in 20 minutes only. Mescaline about 12 hours. Toad, that is very, let's say, toxic substance, is about 20 minutes. It's called toad because it is actually a substance produced in the skin of the toad, and has been discovered and used by native people of some areas, especially, if I don't remember well, but yes, it should be Soronia Desert of Colorado River area, okay? And of course, the short-term effect of psilocybin makes this substance perfect for the use in our therapeutic setting. In the sense that you can have a session with psilocybin in the morning, and in the late afternoon you're completely free of the substance, so very manageable. These are the peyotal bottoms. So psychedelic states, I will just shortly talk about it, because the other presenter will talk more throughoutly about this. We'd say just in general terms, they provide a sense of union with the surrounding, or de-differentiation, so losing of the ego boundaries, heightened inside illuminations that also reflect the increased inputs from the sensory in general. Then an awareness of mystery and ineffability. I mean, that means something that is bringing the mind more in touch with the world, we would say, and especially also an increase in affect, including love, gratitude, but also fear and terror. I chosen this picture to have a little idea of what could be to be in a bad trip, as it's called. So, of course, we have also to inquire a little bit about the relationship with dreaming, and of course, there are common features. For example, mental imagery, emotion activations, but also difference between the two states. that relates to a differential perceptual input that actually is increased from the environment, a clarity of consciousness, and also memory, and an increase in metacognitive abilities. Therefore, well, that's a proposal in a certain sense, but the psychedelic states are probably the closest to the lucid dreaming, which is characterized by the mixed state of dreaming and waking consciousness. That's could be interesting to illustrate a bit what happened with the relationship between Western world and psychedelics. As we may see, the science started to really inquire about the effect of these substances around the 60s, but at a certain point in the 70s, actually in the 70s, the effect of these drugs linked with the, I would say, the counter-establishment culture, especially in the West Coast, was the cause of actually a ban of the use of these substances that were previously legal or semi-legal, and they were completely banned all over the world, also because US had the power also to influence the World Health Organization in this sense. And so the ban was spread all over the countries. And only recently, and that's the psychedelic renaissance, around the 90s, the scientific works on these very, very powerful substances restarted again. And in that atmosphere, because Shulgin was in California as well, if I'm correct, he was a very serious researcher, but he was deeply in love also with psychedelics, and even against law in a way, he continues to study the substances and testing the substances together with his wife, and was the one able to discover or rediscover to a certain extent this psychedelic, the love and rave parties pill, the MDMA. That is actually an amphetamine, so different from classical psychedelics, that has this power to reduce social anxiety and inhibitions. And as usual, we were discussing about the link between euphoria and anesthetic power. That is also a characteristic of MDMA. A good point in favor of these substances is there actually very low power of dependency, and also not very or not at all dangerous for the body. Taking into consideration, for example, heroin or nicotine are much more addictive, while, for example, psilocybin, LSD, or mescaline are not quite not additive. That's very interesting because it means they are much more easy to manage, and as a professional, as doctor, we can use quite safely. These are the data about this is a review of the 2013 on PLOS ONE on population study about the use in longer terms for years and years of these substances. And actually, in several cases, psychedelics use was associated with lower rate of mental health problems. These, we could say, is a side proof of their effect on mental health. So a bit more into neurobiology. Psychedelics, classic ones, function through receptor activation. In this way, they regulated the neural activity because so I'm a little late. So I will running a bit faster, I'm sorry. But anyway, these are the effects. And I would say to stress the neuroplastic effect that also affect memories, by the way, and increasing in connection in synapses. And the alter entropy has to do with the fact that the general organization of the brain goes into a kind of disorganization that is parallel with the ego abolition that is typical of these substances. These are the receptor of serotonin, so we skip it. Also this one. And now is the most theoretical part, in the sense that understanding of the actual mechanism of psychedelics needs a little bit to refer to this theory of inference machine, the brain as a hierarchical inference machine, in which actually a bottom-up sensation from sensory organs are appraised with top-down cortex-derived constructs. It means actually that we do not see reality as it is, but reality we see is completely built up by the brain, to be short. To be a bit more into detail, I think it is maybe the slide that is more important to understand a little bit how it functions. Top-down prediction means cortex mainly. Actually decide the amount of input that came from the sensory organs, in the sense that normally we know what we want to see, and if the input coming from the outside is coherent, what we expect to see is completely automatic process. And this alpha rhythm actually is correlated with the ego function. So the ego is functioning. We have a complete and good enough, I would say, prediction of the external world, so nothing is wrong. When we use psychedelics, actually the power of the top-down prediction reduces markedly. See the difference in how large is this arrow compared to this one, while the input becomes stronger. So the top-down prediction are very little or are published, and all the input from the sensorium is increased. And the brain, of course, goes into confusion, we'll say. I will say the ego is abolished. And we have to restart, say, Freestone to palpate the world again. And that could be an updating of our view of the world. Also a liberation from, I will say, pathological kind of top-down prediction. So we become more flexible and more open to the therapeutic process, for example. Okay, I have to run, evidently. All right, these are not alternative, actually, models of how the psychedelics works. And I will focus only on Rebus. This is by Carhart, Harris, and Freestone, 2018, if I remember well. That is, in short, the hypothesis is that psychedelics make rigid belief revisable by increasing the influence of bottom-up input. But put differently, patients become highly suggestible and sensitive to context during a psychedelic session, amplifying the therapeutic influence and effects. Well, anyway, that's important because that's David Nutt in the last book that is very good about psychedelic use. And that's the connection with Castaneda of the 1973. Quoting him, normally each brain network tends to talk mainly within itself, less to other networks. This way of functioning is called the small world brain. The small world local connectivity relies on all the priors, that is, prediction or beliefs, for every situation we developed from babyhood, so linked, of course, to parenting and to culture. I skip it. And so what happens when you have the psychedelics? When someone takes a psychedelics, it slots into the 2A receptors in the layer 5 neurons all across the brain. This activates and dramatically increases the excitability and firing on these neurons. In our studies, EEG and MEG show this leading to a loss of the brain typical rhythm pattern brain waves, abolition, actually the ego. We saw the strong alpha waves, ego-related, breaking down and being replaced by shallower, unsynchronized waves. This shows that the higher level part of the brain, the default mode networks, which usually integrate all the brain's input, have stopped communicating with each other. The drop in blood flow that we recorded in the first study was the DMA going offline. At the same time, with the DMA offline, any networks start to connect with each other, incrementing the entropy, that is to say, the quantity of information needed to describe a system. So the complexity of the systems increase of the whole brain. Greater connectivity may also explain why people report having important insights under psychedelics, both personal and intellectual. This is a similar process to how you might be struck by new ideas when falling asleep or after sleep, when the DMA also dampens down, allowing your brain to work without its top-down controller getting in the way. So reality isn't out there, it's created by your brain. Conclusion that in the forms of open question, but what I would prefer to quest, only one, for the sake of simplicity. Pharma industry, big pharma, is actively searching for a non-hallucinatory, non-entheogen psychedelic-like substance in order to have a drug more acceptable from institution. Remember the 70s ban. Do you believe, dear colleagues, on the contrary, that the trip, the peak, the mystical experience are essential for a therapeutic effect? Thank you.
We have a lot of questions on table. Okay, on the table we have a lot of to talk about. Yeah, so thank you very much, Francesco, and sorry for I stopped you because we are late, and we would like to go to John Martell. Maybe he's going to and he's going to introduce us to some clinical use of the psilocybin. And John Martell is a psychiatrist, clinical researcher at the Imperial College in London, and above all is pioneering the use of psilocybin. So I think maybe we can learn a lot by you. Thank you very much to be in Rome.
Thank you for that invitation and for that introduction. Much of what I'm going to talk about is based on my experiences of working in these clinical trials with the Imperial team, both as the study doctor and psychiatrist, but also as the co-guide or therapist in this depression, anorexia, and more recently...
Is it better?
Better like that?
Closer. Also closer. Sorry.
So working in these trials and also more recently an OCD trial. As such, much of what I'll be talking about is quite specific to working with psilocybin versus shorter acting psychedelics like DMT or related substances like MDMA. I'll start by briefly touching on the emerging evidence base and where things are at with the regulatory approval, laying a bit of emphasis on how this process comes to influence the knowledge that's produced. With greater depth, I'll outline the extra pharmacological effects, so that's the set and setting, before discussing the three fundamental pillars of the work, so preparation, the dosing sessions, and integration, as practiced in these trials. I'm not suggesting this is a one-size-fits-all model. Different cultures and contexts will require different therapeutic models. I'll briefly survey some of the proposed psychotherapeutic mechanisms before focusing more on the importance of the therapeutic alliance. And finally, I'll zoom out a bit to consider some of the relational or contextual complexities of the work, so the political, cultural, and historical factors that shape the current research agenda. The results from the Imperial Depression trial we were involved in were really encouraging, establishing equivalent efficacy on the primary outcome measure, and with psilocybin-assisted therapy outperforming escitalopram, the antidepressant, on various secondary outcome measures. However, the headline news in terms of treatment pipeline is that last November results of a larger trial in treatment-resistant depression were published, and these are driving a bigger phase 3 study that's just underway. And if successful, this means that this treatment could be licensed for treatment-resistant depression possibly later in 2025, and as soon as that. Perhaps the biggest psychedelic pharma company, Compass Pathways, is behind this phase 3 trial, and in conjunction with the South London and Maudsley Trust and the Institute of Psychiatry in London, there's being built a research clinic for this and similar trials. I think it's important to hold in mind how the regulatory process, research infrastructure, and various stakeholders, especially commercial, interact to contain but inevitably also constrain and limit both the psychedelic experience and the psychotherapeutic process, clinical outcomes, and how we interpret them. As a case in point, it's worth remarking on how Compass's Chief Medical Officer, Professor Guy Goodwin, recently wrote a controversial editorial entitled, "Must Psilocybin Always Assist Psychotherapy?" from which I've entered his conclusion here, and I'll give you half a minute to read through. To his question, I would reply, in clinical populations, pretty much always yes. But I can see why such editorials might be written given the commercial pressures to make this treatment cost effective. 2 therapists attending sessions for the best part of a day, and that's just the dosing session, is very labor and so very cost intensive, and regulatory agencies have limited experience of approving hybrid drug therapy treatments. I was glad Professor Goodwin received a series of excellent letters in response challenging this editorial, including one written by Dr. Gus speaking this afternoon. I think I'm guilty myself, with my own greater interest in psychotherapy and larger knowledge gaps in relation to the neuroscience and psychopharmacology, to rather split in favor of this process being a psychotherapy augmented by pharmacotherapy versus the other way around. And I find Matthew Johnson's comment here about psychedelic therapy a helpful corrective. To go back, yeah. Okay. I can see a little bit of my slide hasn't loaded up here, so you've got some lovely arrows pointing down. I'll try and remember the details, but I'll talk through the slide. It should become clear. To start to answer the question of how the treatment is delivered, it's important to emphasize how the extra pharmacological factors are, in my view, crucial in determining the particular quality of participants' psychedelic experience. And various studies point to the nature of the experience being a key determinant of treatment outcomes. In other words, therapeutic effects are not a simple product of isolated pharmacological action, but rather are experience dependent. To take this further, some participants in the Imperial Depression trial had peak or mystical experiences in the placebo or low-dose psilocybin arm. Some of these participants felt a little sheepish on finding out which arm they were in. But for me, the combined power of expectation, intention, ritual, music, and personality traits such as absorption and suggestibility cannot be underestimated. For those interested, there's a paper called Tripping on Nothing, where psychiatrists and anthropologists at McGill University experimentally reproduce this phenomenon. And of course, this takes us to the more murky ethical terrain of consent in psychedelic therapy. How informed can consent be to states of mind akin to trance, where agency and autonomy is depleted in a process that can lead to, so some of the research suggests, lasting changes in personality and identity? When thinking about the extra pharmacological factors, it's helpful to lean on the archetypal psychedelic trickster and high priest of the LSD counterculture, Timothy Leary, and his concepts of set and setting. In terms of set, the starting point in the depression trial was recruitment. We were looking for participants with whom we felt we could rapidly establish a good rapport or therapeutic alliance, a capacity to trust in their therapists, themselves, the substance and the therapeutic process were foregrounded as important aspects to nurture throughout the preparation process. And this really started from first point of contact with the team. Already we were exploring their early lives, their attachment histories, with a view to nurturing the best therapeutic alliance that we know is a key driver to outcomes in all psychotherapies. A problem I've seen arise in subsequent trials is where therapists who have this level of interest and preoccupation with rapport, trust, and attachment histories are more divorced from screening processes that more exclusively look at diagnostic criteria. Participants with more challenging early lives or attachment histories can struggle to establish the trust required to, among other things, surrender to the experience. Alongside this interest and trust, we were looking for participants to approach the treatment process with a spirit of openness, a personality construct linked to suggestibility that has a more contentious ethical history within psychology. It's important to hold in mind this level of thought and care given to recruiting the right participants. Dramatic effect sizes in these trials are relevant to tightly selected patient cohorts falling within a diagnostic category with enormous heterogeneity. More adverse events will emerge if and when the treatment is licensed and given for patients for whom this kind of therapy is not suitable, especially when drives to cut costs reduce the psychotherapeutic support. In terms of setting, I think many people will be familiar with images like this of our somewhat best efforts at student bedsit interior design, camouflaging the institution. I'm delighted to hear purpose-built clinics moving things forward here. although closer scrutiny of the style of furnishings, decor, and general image that's projected in these kinds of clinics over time might be interesting. As more people access this kind of treatment, more adverse events will emerge and anxieties might grow as it approaches broader cultural and medical legitimacy. Whilst I think participants really appreciate the sterile and harsh ambience of the biomedical being muted in the room, I think many probably felt reassured that just outside the room there are crash trolleys, medical doctors, and lots of anancastic research nurses. The importance of music cannot be overstated. I mention a paper written from an earlier pilot study that captures the primacy of the musical experience. It found that the nature of people's musical experience significantly predicted reduction in depressive symptoms 1 week after psilocybin, in contrast to the experience of drug intensity. We encouraged the use of eye shades to facilitate engagement with their internal intrapsychic world versus the potential for a more superficially distracting experience of perceptual distortion in the room. And this practice was recently given some validity in a recent paper by Pedro Mediano and colleagues, who found the entropic brain effect is greater when external sensory complexity is minimal. In the preparation session, we'd review their mental states, continue discussion around early parts of their life that they felt might be connected with their current difficulties, and more generally, look to deepen trust and the therapeutic rapport. We'd provide an opportunity to air shameful, difficult, frightening aspects of their history or self-experience, and we'd offer tips, explanations of how things can go in sessions, and mantras like trust, let go, be open, that can offer a kind of linguistic scaffolding or support rail during the experience. We explored the possibility of challenging experiences and how these can be beneficial if leading to insight or catharsis. We'd run through a visualization exercise, an exercise in surrendering to a more embodied experience to disturb ruminative loops. And finally, we'd look at intentions, a long-standing staple of psychedelic therapy, and another practice that was given more empirical validity in a paper published just this week, linking intention setting with more mystical experiences in naturalistic settings. As a little addendum, I might add that in the most recent OCD trial, where a smaller mid-range dose had been used, all preparation and integration sessions were done online. I think for participants with more complex early lives or attachment histories, this is inadequate at best, and at worst could in some cases actually exacerbate the potential for harm. So what do therapists actually do in the room? Leo Zeff, a psychologist who worked in the underground, once wrote, "When it worked, the therapist was just a bystander." This is often true, and the treatment's arguably all the more powerful when patients feel a greater sense of creative agency over their experience. However, the statement doesn't capture how crucial it is the quality of presence that guides or therapists bring to the session. Ideally, we'd offer an unspoken containment that allows participants to let go and yet feel held at a deeper level, in keeping with the analyst Daniel Stern's concept of the framing environment. Such a concept's helpful if we remember to what degree the experience could be viewed as a regression, both in terms of the brain state and the psychodynamic situation of what's often a parental therapist couple tending to someone vulnerable in need of care and support. The therapeutic use of touch was used, generally taking hold of their hand or wrist, but sparingly and with discussion, practice, and consent. It is and will remain a contentious area within psychedelic-assisted therapies, where the very essence of the psychedelic experience could be described as one of shifting boundaries between different perceptions, the experience of time, and self and other. Integration in the depression trial happened the following morning, and in this trial we worked with a model called ACE, or Accept, Connect and Embody, developed by Dr. Ros Watts, that draws on acceptance and commitment therapy and emphasizes psychological flexibility and metacognitive capacities. This emphasis marries well with both the neuroscience of the psychedelic brain and anthropological literature on general mechanisms of therapeutic action across different modalities that proposes many forms of healing, including psychotherapy, work by inducing psychological states marked by flexibility or an enhanced ability to shift cognitive sets. We adopted an open, flexible and humanistic approach over something more structured and directive, and we used a funnel analogy to capture how we would slowly try to distill what's often experienced initially as chaotic and beyond language. Of course, in many cases, this metaphor was ill-suited to a more complex and messy process. In hindsight, I feel opportunities were missed in this trial, with more relational and transference-based thinking not so much as excluded, but certainly taking more of a back seat within this emerging therapeutic model. I should add that in the anorexia trial, the model was strongly informed by emotion-focused family therapy that I think was particularly well-suited to this clinical population. And in keeping with this more systemic lens, I think it was of great value that the protocol included a member of the trial team working with a named support person to the participant to help manage some of the dissonance and disturbance to relationships that can emerge from a family member undergoing a profound and transformative experience. I'd now like to turn to think about psychological mechanisms of change that might be at play. Two key researchers of the earlier phase of research, Betty Eisner and Sidney Cohen, they wrote in 1958 that LSD lessens defensiveness, there's a heightened capacity to relive early experiences with accompanying release of feelings, therapist-patient relationships are enhanced, and there's an increased appearance of unconscious material. Most investigators report that therapeutic benefit can occur through any one or more of these factors. You can see the language of psychoanalysis more readily and authoritatively deployed here, in keeping with the stronger hold the discipline had within the professions and research agenda of the day. And these proposed therapeutic mechanisms remain embedded in contemporary thinking around psychedelic therapy, albeit allied to more computational and neuroscientific models and metaphors, like Carl Friston and Robin Carhart-Harris's Rebus model, where they act as belief relaxants, cognitive lubricants, they shake up the snow globe. However, a bit like in psychopharmacology with Me Too drugs, where antidepressant molecules are tweaked for new indications and slices of the market cake, we now have a proliferation of different psychotherapeutic approaches assisting the administration of the psychedelic. In a recent review entitled Psychedelic-Assisted Psychotherapy, Where is the Psychotherapy Research?, the following approaches were listed. You can see it's quite long. And this same review lists various putative mechanisms, or mystical type experiences, acceptance, decreased rumination, cognitive flexibility, and lastly, the therapeutic alliance. I want to focus a little on this final mechanism that my colleague from the depression trial, Roberta Murphy, looked into in greater detail. As we were working as both psychiatrists involved in screening and therapists working more closely with participants in their journey, we were in a privileged position to follow them from beginning to end. And as a team, we were getting really interested in what the difference was between those who seemed to be able to surrender to the experiences and who generally improved clinically by the end, compared to those who had a rockier or more difficult journey, perhaps didn't seem to experience much on the dosing day, who sometimes left the trial still depressed and even angry or disappointed. And connected to that, lots of questions about the mechanisms of change, who responds and why or how. And researchers have started to think about two important flavors of psychedelic experience. One is the mystical experience, positive mood, ineffability, a sense of sacredness and unity, transcendence, deep connection. And the other is emotional breakthrough. So experiencing emotional release or catharsis after facing and overcoming difficult or previously inaccessible emotions or memories, and gaining personal and or interpersonal insights, this latter being much more closely linked to the kinds of ideas we'd hear about in traditional talking therapies. And as I mentioned earlier, research has shown that the intensity or the quality of the acute psychedelic experience, i.e. high scores on mystical experience questionnaires and emotional breakthrough questionnaires, these link to greater clinical improvement. So looking at our countertransference, we wondered whether the differentiating factor in how people did was something about what the therapeutic relationship felt like. If the participant seemed to trust us, if it felt safe between us, which makes sense as we know the strength of the therapeutic alliance, a measure, the strength of the relationship, has been shown to be one of the strongest predictors of outcomes in all kinds of therapeutic modalities. So why not in psychedelic-assisted therapy? Based on these ideas, Roberta decided to investigate the role of the therapeutic relationship in the experiences of the participants, and her hypothesis was that a strong relationship would predict bigger experiences, higher scores on mystical experience, more emotional breakthrough, which ultimately would predict improved depression scores. And the results confirmed her hypothesis. So the rapport or therapeutic alliance predicted greater emotional breakthrough and mystical experiences, which predicted final changes in depression scores. The therapeutic relationship was important throughout the study, and there was a reciprocal relationship between the quality of the experience and the relationship, one leading onto the other. And of course, those who didn't have that trust had lower scores of emotional breakthrough and mystical experience, and much less change in their depression scores. So really supporting the idea of a patient needing to feel safe and contained in the therapeutic relationship in order to open up to the vulnerabilities of a psychedelic experience, to allow that unconscious material to emerge that might create meaningful change for them. And of course, it's important to keep in mind that as with all psychotherapies, there are probably lots of parallel streams of relational healing at play. There's the way that the therapeutic relationship supports people to be able to really go into the experience, for example. At a more explicit verbal level, this might include gaining insights or narrative building, understanding one's relational pattern and perhaps their early origins, but there's also something about the experience of being in potentially a very regressed or vulnerable state with one's guides or therapists, feeling cared for and supported in a way that one might feel they didn't experience in early life, that might provide a more experiential or even embodied healing experience. Of course, a related question is what might determine the therapeutic alliance, and we know, of course, there are therapist factors, things like our own interpersonal disposition or attachment style, which of course is influenced by our own personal therapy or self-work. The depth and quality of a therapist's training and experience, and the depth and quality of the supervision supporting the work are key. And with patient factors, of course, we can think about how they relate, their attachment style, or to use more psychoanalytic language, the quality of their object relations, which, along with possible genetic factors, is often heavily influenced by early experiences of attachment figures and early relational trauma. And practically, what this indicates is that with people or cases where building that trust is really challenging, we might need to support the work in different ways. For example, a much longer preparation period prior to dosing, allowing additional time to build that trust. This kind of evidence might help us to think about where someone might need to be therapeutically or even relationally to really avail of a psychedelic session. which will be particularly relevant if, for example, when licensed, it's a very expensive treatment, which it probably will be. We will really want to think very carefully about these things. When in a therapeutic process is a good time to use a psychedelic? Where might the patient or even the therapeutic relationship need to be? And here is where we can start to think about the nuances and complexities of this work. Much of the media narrative around psychedelics as an emerging treatment is of positive relationships, powerful psychedelic experiences, and large treatment effects by the end of a very short time. But we know, of course, that change in psychotherapy can involve working over longer periods of time with very deep feelings of mistrust or lack of safety in the relationship, or to put it in more technical terms, working with a negative transference. Keeping in mind the complexity of this work, it's clear to me that in the future we'll need to have more flexibility with longer term pieces of work that clinical trials tend not to offer. But again come questions around cost effectiveness. What systems of care will deliver for those patient groups who don't fit into the short case model espoused by the trial data? I'd now like to widen the lens a little further, both beyond and to include our biomedical gaze. The sociologist Ida Hartogson describes psychedelics as a psychopharmacological chameleon in his book, American Trip. What he means by this is that pharmacologically, they render users exquisitely sensitive to their environment or context. This can be their immediate physical and interpersonal environment, their own internal world, but also the broader social unconscious. So the psychedelic experience hasn't just come to shape culture, but culture shapes the psychedelic experience. And I'm fond of this quote from the psychiatrist and anthropologist Lawrence Kermeyer, who describes the psychedelic mind is akin to a clay sculpture that, when wet, becomes more pliable and therefore more readily shaped by the forces of culture and context. A bit like having Freudian dreams if you go to a Freudian analyst, and Jungian dreams if you go to see a Jungian analyst, commentators have remarked on the greater likelihood of mystical type experiences at Johns Hopkins trials in the US versus more emotionally cathartic ones at Imperial, as a product of the differing institutional cultures and intellectual or spiritual proclivities of their researchers. Similarly, the commercial imperative to develop psychotherapeutic treatment protocols that are scalable to reduce costs will come to shape the variety and nature of psychedelic experiences that health systems can contain and work with. Should more psychodynamically or relationally informed work be marginalized, this will, in my view, likely increase the risk of adverse events. An amalgam of different cases that springs to mind was where a participant locked themselves in the toilet for nearly an hour during a high-dose session. They were confused and frightened. Through understanding a bit of their attachment history, we were able to see how it was possible that a powerful negative paternal transference was emerging against myself in the context of the participant's cold and emotionally unavailable father, and against my co-therapist who came to represent a much longed-for maternal figure, who nevertheless could never meet nor contain the participant's emotional needs as a child. Growing up, this participant often retreated to the toilet in the family home to literally find their own mind. The participant quite explicitly confirmed our hunch of how we were being experienced. Being able to think together with the participant about this felt crucial to transforming what might easily have spiraled into a more harmful and destructive experience into one of greater understanding, self-compassion, and growth. We know that man's used psychedelics for millennia. They're of social, sacramental, and/or therapeutic value when used in conjunction with a cultural container that's evolved to suit their use. I feel this perspective necessarily problematizes the question of therapeutic potential. The Western biomedical paradigm prioritizes the production of particular types of knowledge, of which the double-blind RCT is one we're especially enchanted by. Whilst there's the colourful history of the prohibition of research following psychedelics leaking out of the laboratory container and lubricating the counterculture, a more prosaic one has its origin with the thalidomide scandal that ushered in the Kefauver-Harris amendments in the US. This was legislation designed to safeguard against such tragedies by foregrounding the methodological rigour of the double-blind RCT. The historian Matthew Oram points to how funding for psychedelic research dried out not just from the substances falling foul of the war on drugs, but because researchers struggled to meet the exacting demands of a research methodology poorly suited to this kind of therapy. Today, blinding remains nigh on impossible. Active placebos simply don't cut the mustard. There are significant cultural looping effects around the hype, driving high expectancy and, conversely, nocebo in those in control arms, thereby inflating effect sizes. The anthropologist Daniel Gifford, in her book Acid Revival, The Psychedelic Renaissance and the Quest for Medical Legitimacy, is especially good on drawing attention to how the ghost of Timothy Leary continues to haunt the way the science is performed by researchers who, over and beyond the demands of regulators, are preoccupied with how it's perceived by mainstream audiences. I wonder if this self-consciousness might explain some of our fetishization of the double-blind RCT that's ill-suited to the task of establishing efficacy with psychotherapies. Much like many psychoanalytic writers refer to Freud as a form of rhetoric to reassure readers and themselves of their allegiance to the boundaries of their guild, we must invoke the cult of evidence-based medicine. Debts are paid and gravitas accrued. Greater awareness of this performative aspect to the science, contingent on cultural and political histories, would, I hope, engender some epistemic humility at our findings and keep the door open to a plurality of perspectives on whether and how psychedelics might work, whatever we mean by this. I'm glad to say there is growing discussion around the limitations of the double-blind RCT for exploring psychedelic-assisted therapies. Timmy Davis of the Centre for Evidence-Based Drugs Policy has astutely pointed out that in the act of honouring indigenous use of plant medicines, as of course we should, psychedelic medical discourse projects out all the messy but powerful contextual factors that goes on in psychedelic therapy, expectancy, ritual, and suggestibility, for example. These are, up until recently at least, generally portrayed as unwelcome guests in a clinical trial research paradigm so fond of isolating drug effects from the context within which it's given. Researchers at King's are asking how meaningful it is to tease apart the synergy between psychotherapeutic mechanisms, drug effects, and common factors in therapy like expectancy and the alliance. More boldly, the likes of Tessin Narani and others, in a paper enticingly called Dark Loops, Contagion Effects, Consistency, and Chemosocial Matrices in Psychedelic-Assisted Therapy Trials, points to how the cultural looping effects driving strong outcomes could, rather than being viewed as contaminants to the research, actually be harnessed, inviting in placebo science. And this invitation is more explicitly stated in another recent paper entitled Harnessing Placebo, Lessons from Psychedelic Science. Questions around the medicalization of psychedelics, I hope, might provoke questions around the psychedelicization of medicine. I particularly like the call for humility in all of this work in a letter written by Dr. Eduardo Schenberg to a medical journal entitled "With Sneaky Subversion, Who is Blind in Psychedelic Research?" And I'll just let you read that. On being kicked out of Harvard, Timothy Leary famously said that he was through playing the science game. I don't consider the science a game, as alternative treatments for depression, for example, are desperately needed. But I hope that what I've touched on illuminates ways in which the current research paradigm and its largely biomedical container might obscure various relational and contextual complexities to the work. It's not being performed in a social and political vacuum, but quite a messy petri dish with a lot of powerful cultural baggage that needs to be respected. Looking to the future, if and when the treatment is licensed, these aspects of the work might help us in considering, among those with a diagnosis like treatment-resistant depression, who is and who is not suitable for this treatment as it's packaged or delivered in particular health systems, services or teams, given the likely high costs associated. I'll give the final word to the sociologist William Cameron, where he counsels on the tyranny of measurement. Not everything that counts can be counted, and not everything that can be counted counts. Thank you.
Oh, thank you very much, John. I wrote down a lot of notes. I cannot read all these notes. So, just a word before going to have a coffee break, okay? So, as a psychoanalyst, we know very well the mechanism of uncanny, yeah, it's something familiar which comes back unfamiliar, not common, changed, transformed. This is my feeling today with John, because he talked about transfer to countertransference, alliance, therapeutic relationship, and defenses, resistance, but in a different way. So I thought it was a moment when I thought, oh my God, this is a miracle. We can give all this to our patients without going on with working through transference, procedure, processes, and many, many years of psychotherapy. So, shortly, this is not what we are saying or what John is saying. I think the direction is looking for the common ground in order to support the hard rock of the resistance in psychotherapy, I think. So we have half minutes of a coffee break, then think about this, and we open the dialogues, the discussions between psychotherapy and drug treatments, okay? See you later. So, if someone wants to open this discussion with Francesco and John, I don't know, in Tedesco I cannot say uncanny, unheimlich, okay? Okay, this is unheimlich. So this is the feeling, the sensation today, because Johnny and Francesco, thank you very much to both of you. They talked about something we know very well. We know very well because it's something we encountered, we met in our training, in the treatment day by day. So we have this common ground about alliance, therapeutic alliance, about containment, about integration. Integration is a form of working through for us. And a lot of, I would like to ask a lot of questions I have in mind. But so before my questions, I would like to listen to you, your impression, your suggestions. So go.
So I'm Michael Brück from Germany, Heidelberg. First of all, I want to express my deep, deep gratitude to both of you presenters. Because, to be honest, yesterday I was wondering, will we touch the state of altered states? But you both have touched it. And so on a scientific way, but also with the awareness of what kind of work is opening up if you do this work. And I just want to rely to you, John. What you're doing there in London, in my opinion, is something which is part of what was happening in the 70s, 80s, and 90s in a little bit sterilized setting of clinical work. And I want just also to express here in the audience that I like very much that you are aware how difficult it is to make research in this field. Because to put it in very simple word only, this work has to do with surrender to whatever it is inside, which is very similar to psychoanalysis, because free association has also to do with surrender, whatever it is inside, and not to forget to transport it to the outside, to the analyst, or whoever it is. So there's a big, huge similarity between psychedelic work and psychoanalysis in this basic frame. So I just want not to put a question here, but just to give you my high thank you and gratitude that you opened up in a world where it's still on the edge to be dangerous, because for me it's also the first time in a psychoanalytic setting that you may have a feeling, I have connection with this work, but it would be very dangerous in certain circles to speak about this 5 or 10 years ago. So I'm thanking also the organizational committee to open up this space in our psychoanalytic community. Thank you very much. Mille grazie.
Thank you, thank you. We are not on the edge of mind breakdown, so we can talk about this now, okay? Okay, John or... No. Okay, yes, okay. Alessandro, go.
Thank you, friends, for your wonderful contributions. And I have two questions, one for Francesco and one for Johnny. Almost 50 years ago, I discussed an interdisciplinary thesis on LSD and altered state of consciousness. And I proposed, the thesis was in biology, I proposed a model in which I thought that the main action of the LSD could be in the Raphe nucleus, where there are negative feedback circuits among different Raphe nucleus. So because LSD is an agonist, so the effect is inhibitory, and it works at so little amount, something like homeopathic, I thought that the first action is in this place, and he created a double inhibition, so he inhibits the whole serotoninergic system, who comes ascendant, bottom up, and the serotonin system first interact with the transit station of the sensoriality at thalamic level for example, nucleus genicolato laterale and nucleus genicolato mediale, which are very interesting for this period of crossing between visual and acoustic. So the decreasing of serotonin in this point, I think, make the filter more elastic, more after serotoninergics act in the amygdala and the limbic system, and at the end on the cortex. But I think the main action is in the raphe nucleus. The result is a general increasing arousal, decreasing of redundance in vertical process of sensoriality, and an increasing of entropy and entanglement among the horizontal associative connection in the transit station and also in the limbic system and maybe in the associative cortex. Anyway, so the result is a decreasing of rigidity of the whole system, whole mental system, decreasing of usual beliefs of which we interpret the world, and increasing of plasticity, mobility, and strong dependence from the context and the setting in which the experience has been done. This is, I would like to know your opinion. And for Johnny, it's very interesting. I would like to, Johnny, what about the training of the therapist? So should the therapist make personal experience to manage this kind of substance? Generally speaking, we say that the therapist must be lucid, but we are still far away in comparison with shamans. For example, Maria Sabina, well-known Maria Sabina in Mexico, who Osmond met her, and Alfred Hoffman. Maria Sabina used to take care of a patient in one night, giving mushroom to all the patients, and he took a double doses herself. Of course, this is more difficult to imagine, to manage. Another question in groups. What about experience in groups? I lead groups, so I thought to preparing the experience, we can use the group first and after to reintegrate the experience, but also share the experience in groups, including the therapist. Thank you.
John or Francesco? Who starts?
Well, yes, the question about, the model you proposed, I wonder when it was, in the sense it was before probably the fMRI revolution.
The Agajanian paper works.
Well, it was in the 70s, 80s, so probably before the fMRI. And actually it's confirmed, that's the theory of thalamic gating, it was in the picture as well, in which exactly the influence of the priors of higher level, that means the cortex of the 5-layer pyramidal neurons, is abolished. In that sense, having no priors to read the reality, we'll say, the input from reality is stronger, is more accepted. In this way, it changed the way we see the world. That's the thalamic gating theory. Yeah, exactly, that's more or less, that's the metaphor. And actually the part of the brain we are referring to is also probably more precisely labeled as the geniculate cortex. That's the part of the default mode network that is rich with the serotonin receptors and is affected by psychedelics. And what's interesting is some studies have been done during the, for example, the symptom of loss of body or disembodied hallucination, out-of-body experience. And it seems to be linked to the posterior part of the geniculate cortex. So it's specific for this kind of symptoms. And that's the advantage of having this kind of imaging, tools to understand how the brain works and how the psychedelics or any drugs works. So very specific.
Yeah, there's a lot to say about training. I think the first thing to say is that if these treatments get regulatory approval, there's going to be an enormous demand for therapists. There's going to be a supply and demand problem, and training institutes are sprouting up. I worry a little bit about the drive to produce therapists working to protocols which are scalable. A related question is around the quality of supervision, which is going to be crucial, and systems of supervision for the work and the containment around it. I have my own bias. I'm more interested in psychodynamic, psychoanalytic work, despite not being a psychoanalyst. I really hope that that thinking continues to inform the work, even if a treatment protocol is more, for instance, say, ACT, acceptance commitment therapy. My hope is the supervision and the supervisory structures will have that way of thinking. They'll be breathing that kind of thinking relationally. The personal experience question is a very thorny one with a very rich history, because part of the reason why the research got shut down last time around was because the researchers could be portrayed as kind of a bunch of hippies getting drunk on their own Kool-Aid. So one needs to tread quite carefully. One needs to be conscious of, I guess, cultural perception of the science and the authority that's invested in that authority. I have my own views on the need for therapists having their own personal experience. One way of answering it would be, if I was a participant, would I rather have two therapists who are extremely experienced psychotherapists with great kind of confidence within the process that could be emerging, or two incredibly experienced guides working in retreat settings with limited psychotherapy experience? I would rather go for very experienced psychotherapists. Myself, in a trial I've worked with a therapist who didn't have any psychedelic experience, but because she was so good and such an expert on eating disorders, as a kind of therapist couple, I think we worked pretty well. I don't feel comfortable with the idea of a therapist couple doing psychedelic work, neither of the therapists having an experience of altered states, and I think that also opens up the question, does it need to be psychedelics? There are other ways of attaining altered states, like breath work, which can be quite powerful. But there's lots of questions around legality of these trainings. There's an excellent one growing in the UK, but it's taking in small cohorts of therapists. And of course, to have the experience, that would need to be abroad. So to answer these questions, you need to think about the health economics of it. Boring, but kind of important. The groups thing, that for me is kind of a no-brainer. It will have to go that way for it to be cost-effective. And as you said, it can be quite easily done, the preparation and the integration in a group setting. Obviously, all of the content of the individual's sessions, experiences can't be explored to the same depth, so you lose something, but you also gain something. People that work with groups, there's huge power in that. And also, arguably, as psychedelic therapy is being practiced, quite often the focus on the individual, one could argue, is reinforcing something about the sort of biomedical model of psychopathology, where all the pathology, the disorder, is located in the individual, as opposed to being contextual, relational, and broader socioeconomic factors driving the distress or the pathology. So I think the group model has a lot to offer on lots of levels. In terms of holding sessions themselves, I don't have any experience with that at all myself. I think in Switzerland, Peter Gasser's doing that. And of course, we know from indigenous societies that's the norm. You touched on Maria Sabina and other shamans ingesting psychedelics and doing the work. I think that again challenges the idea, the authority that's invested in our own culture of expertise, whether it's clinicians or researchers. I think there's always a slight danger of romanticizing and idealizing other cultures' ways of doing things. We can learn a great deal from them, but we also need to respect what we can offer and our ways of doing things. I'll leave it there.
Okay, I go to Heribert Blas first, and Heribert, yeah? And then I bounce to the online questions, and then you. So we bounce from the floor to the online, okay?
Yeah, thank you very much to both of you for your excellent presentations. I come from a psychoanalytic point of view, and I want to ask a question from psychoanalysis. At first, Francesco, thank you very much also for the history. They see that there is in mankind there is a long history of the use of psychedelic drugs, and now we are faced with this again. And my impression, as according to your John presentation, that we as clinicians are dealing with very severe psychic states. So it was chronic depression, for instance, yeah? And I think that we are always looking for some means to deal with very severe, also psychiatric diseases. And my question first is, when I go to the issue of surrender, what Misha said, I think I could compare also this, what you presented us, to some psychodynamic concepts, like for instance, to be in a relationship which allows deep dependency. So you spoke of surrender, I would speak of deep dependency. And this is very important, and so I'm very grateful also that you just emphasized the fact that there is a relationship. This may be also related to the group processes. Yeah? So that it's not only something which is happening inside the person, but there is a relationship. But to be short, my question is, I was thinking about the fact that Freud gave up hypnosis. And my question is, because one of his ideas, this relates to Mark's presentation yesterday, was there has to be now a kind of consciousness what's happening. Now, yesterday we learned that the consciousness is an affective consciousness. Nevertheless, I personally would think that we need also a connection to language so that we have affective experiences and to language. My question to you, to be short, can you tell us something about what we in psychoanalysis call transformation? So what is a psychic transformation? So what is happening after these individual sessions, which you presented so very well? Do you have some experience whether they remain? Yeah? So Freud had, for instance, the impression hypnosis is working, but it doesn't remain. So what's about the remaining results?
Yeah, do they remain, the experiences? I mean, I suppose on a more concrete level, I can't give you the precise data across various depression trials, but people tend to relapse. I suppose what's coming to mind to me just in being here with a room full of psychoanalysts is the work you guys do over a very long period of time working through. And in psychedelic therapy, we are, an aggressive word, but smashing through defenses. There can be huge change, but I think I put a slide up from Adam Phillips, which speaks to the profound ambivalence we all feel around change. And I think also some of that ambivalence that he's driving at in that book on wanting to change is how we relate to authorities that deliver that change for us and the power. I can feel myself sort of starting to free associate to a very clear question. What remains? What happens, I guess, on a sort of fairly simple level in the integration sessions is we start to use language again. And in using language, we obviously structure and in some ways close down something which is ineffable. So I think there's really kind of a dance and some tension in wanting to hold on to something which, as humans, we don't have the tools to capture. And the very act of capturing itself, something is lost. Yeah, those are a few early, somewhat abstract thoughts to your question.
Francesco?
Yes, if I can add something. The point about transformations, no? Okay. Quoting you, or better dance the Greek again, no? This know thyself, know yourself, should be enlarged with knowing your limits, your place, and then yourself. My understanding of it, using the inferential theory of the mind, is that we have a Markov blanket that is limits and boundaries that define ourselves. And then we have to live and survive inside an ecological niche that, in a relational point of view, is our fellows, our father, our mothers, our sisters, our friends, whatever. And we have to live within this relationship. And then there is the self. The self is more understandable also according to Freestone with active inference, that is, make an inference prediction in an active way. That means planning, knowing your present and predicting your future, okay? That's the frame. When we talk about transformations, of course, transference has to do with an emotional bonding within the patient and the therapist. And it should last for long, because we have to go into the ecological niche of the patient for a long time. And probably psychedelics breaks, I mean, the priors in this sense, the previous setting, where we have to provide another one. That's why trust is essential.
It's the same questions we asked to someone 2 or 3 years ago about mindfulness. When this content comes to the mind on consciousness, what you can do with this content, okay? What kind of elaboration is possible? So I needed to bounce to the online, because there is a very interesting question about dreaming. They're asking if at the Imperial College you have some sort of experience from psychedelic treatment and dreaming. You harvested the dreaming. You have something about dreaming, okay? But I would like to say something about this, because there is another question about lucid dream. Okay, it's not an easy question. This is really not an easy question. Consider this. Alessandro said something about the raphe nucleus. The raphe nucleus is a really important station between the balancement between serotonin, adrenaline, and the dopamine. In the stage 2, on the second stage of the sleep, when this balancement change, we have the REM sleep. It's the same. If this balancement doesn't work and the frontal system doesn't work, so we have the lucid dream. So someone asked if the experience with psilocybin and psychedelics is the same of lucid dream. I think it's not the same, because the lucid dream, we can control the process of the dream, but we cannot control the content of the dream. So partly we can control, and above all, because when we know at this moment, immediately we know we are in the dream, we know the agents knows we are dreaming, we stop dreaming, no? We are awake, and so the reality comes. You need a lot of training to control this process. So maybe this is some point of difference between the use of trips, trips, bad trips, and so psychedelics, and dream and lucid dream.
Yeah, I don't think I'm qualified really to talk about lucid dreaming and how that might be different. The only thing which really comes to mind for me is the sense of agency in both different states. And I suppose one axis to think about what might be therapeutic in the psychedelic state is around experiential acceptance versus avoidance. And I suppose, is there a question in accepting the experiences which is emerging within you, you're surrendering, succumbing to processes you don't have control over, versus in lucid dreaming, my very sketchy understanding is that you do have more agency. Those are the first kind of thoughts I have, but yeah, I'm not qualified to talk about really the phenomenology or neuroscience of lucid dreaming. You might have something to add.
Well, I would say that, yes, acceptance of dreaming and of the content of dreaming is absolutely therapeutic, but we know very well that acceptance has to do with containment. And that's back to reality. It means to be back to a relationship. So you can't really dream and elaborate something that is traumatic without the help and the support of a human being. That's my experience. And I would say that maybe the psychedelics are a sort of medium of the relationship. I give you something powerful, you believe in it, you believe in me, and that's the therapeutic process start. Something like a trick to a certain extent. That's also explaining the placebo effect and the transferential effect. So of course the intake phase, preliminary phases are essential. There is a matching or not between me and this person. You will accept to come with me in areas that are being traumatic. Your reference to early traumatic experience is central in this sense. We are talking about something that has been not possible to talk about when we talk about trauma, no? This early stage of life. So regression, again. But it's something that in psychoanalysis has been, explored a lot. Even though I don't think many of us are really experienced about training this area. Maybe more the child analyst, maybe more someone that has been training, observing the child and the mother and the relationship with the family. This is something that, in my opinion, should be mandatory, and is not. It's impossible to treat an adult without knowing what the baby is. But knowing is experiencing, is not reading a book.
Turn off. Okay. Andrea Clarish, I think. Andrea.
Thank you for both presentations. I would like to make a very short comment to Francesco's one and a technical question to Dr. Martell's. To Francesco, I'm very grateful of of the hints you made and the links, in particular to the predictive coding and the free energy principle in connection to this topic. In particular, to go from simple to more complex issues. When you made the definition of entropy, you said, I have to read it, the quantity of information necessary to describe the system. And I think it's important also to make the addendum, the additions, that the quantity necessary to describe the system to the system, which brings in the story again the subjective point of view, but also to the system in relation. I mean, it's just a comment from you in relation to other systems. And also that you brought, just a comment and to see if you agree, and you brought also into the story the question of trust. Because linking this to the topic of our Congress, I think it's a matter of trust whether you can live this experience in which you add something can give a very intense experience and bring it towards a fearful experience, a bad trip, or an enlightening experience. I mean, it really depends on the relational side of the story. So I would like maybe if you can make a comment on that. And about Dr. Martell's question, which will be very short, for the same reason, I think the technical issue here is to understand whether you think this treatment can change the very infantile procedural memories that we are tackling with working through, which is the difference between symptomatic therapy or a psychoanalytical one. Thank you.
So, Francesco.
Thank you, Ernesto. I'm sorry, it was a joke between us yesterday. And thank you, because it's a very good point to enlarge, because of course the predictive model run the risk to be taken only on the third person, too external. Your translation is very good in this sense. It opens the topic of synchrony between Markov bunkers, let's say between cells, between individuals, between group of people, how they interact, how this interaction could be described in physical and mechanical statistics terms. What is really interesting, that synchrony is actually a physical phenomenon that could be applied also to non-living being. For example, if you put several clocks with a pendulum in the same room, they start after a time to be in synchrony. Synchrony means various things, and not only exactly together, but also counterphase. But it's always synchrony. They influence each other. And actually that's something that seems to happen also between living beings, even cells. And that's an explanation on physical terms of how we communicate with each other. And that's trust. The problem of pathology, or one of the description of pathology, or I will say of pain, leaving aside the biomedical kind of description, is that the individual tends to isolate. And that's increased the level of pain, because we are continually exchanging information that's basic for our survival. This kind of isolation, of course, is rigidity. And to break it, maybe an experience could make the difference. Even psychedelic drugs, and then start the works. That's just the beginning.
Yeah, to your question about in this work actually, or how this work might relate to infantile procedural memories, I think people's experiences can get quite close to them in terms of actually sort of accessing them or reliving them. I think that's probably fairly rare, but I think if some psychotherapy might be working backwards from current lives, current symptoms, to what might have been going on in very early parts of people's lives. What I've experienced with some participants is, whilst they might have a particular narrative about their very early life from their own therapy, which is quite an intellectual one, what I think can be very powerful in this work is that alongside revisiting those early stories, there's kind of an affective storm which goes alongside it, and that I think it's that a sort of felt experience that can power restructuring their story or their sense of self. So it's actually feeling something akin to what they could have been feeling very early on. So it's, for me, the emotional states that the work up to that point hasn't got close to and can do in psychedelic therapy. But I wouldn't like to speak to the frequency or how close it gets to accessing those procedural memories or reliving them.
Okay, would you like to respond to this one, or we go on? Yeah. It's a really technical question, so, one, because we have online the people, it's okay, they want to say something. The question is about the risk of adverse effects, maybe in a psychosis, maybe with this kind of receptor. Yeah. So you can say something?
So yeah, there are three things which are raised in the question. So valvular pathology, so serotonergic receptors on heart valves, and I think the main concern is with microdosing over very long periods of time, could you get hypertrophy of the valves? My understanding is there's not good long-term data, but theoretically it's a real concern. It makes complete sense. The other concern was around visual snow. So the DSM term is something like hallucinogen persisting perceptual disorder. And there's an organization which has sprouted up recently to try and put into the public domain that this is a phenomenon that people suffer from, and they're trying to tease out how people get better over time, why some people don't. More broadly, I think Jeffrey Guss uses the term cultural idealization around psychedelics. What we tend to see in the media currently are mostly the good stories, the good results. People are suffering from these trials. People are suffering from use in other naturalistic settings. The pendulum will swing back to shine more light on some of these adverse effects, and the final one was psychosis. People in trials are excluded with a history of psychosis or a family history of psychosis. There's some work being done in the US by a researcher called Haley Duron, who's questioning whether the exclusion of these personal and family histories is overstepping the mark. But again, more stories are emerging of protracted difficulties after participation in research. And the numbers will inevitably increase if and when the treatments are licensed and people aren't screened out to the same degree as they are, because mostly we're not seeing episodes of psychosis or protracted paranoia in the research setting. But we are pouring in huge amounts of time, resources, and care to contain participants, which will not exist when whatever systems of care deliver these treatments.
Okay, we have this guy. Yes, go. This guy. I don't know your name. Maybe you can introduce yourself.
Thank you. Thank you for the interesting presentations. I'm Mario. I introduce myself. And I was wondering regarding the Dr. Martell presentation, there was actually a key question that he said should be answered, and it is at what point of the therapeutic process and the therapeutic relationship psychedelic treatment should happen and could happen. I suppose it's still an open question, so that's why probably there wasn't an answer. But I was wondering if there is any data-driven or even an anecdotal points regarding these questions to assess. And regarding the therapeutic factors, I believe that the phenomenological side of psychedelic experience is actually key. I heard somewhere, I read about this concept, which I found quite interesting. I don't remember exactly where, which is about effing the ineffable. And I felt that it's kind of related to the psychedelic experience and the psychedelic process, psychotherapeutic process. I wonder if you have any insights or considerations about these concepts and its possible implications. And thanks again for the introduction, the presentations.
I think it's worth holding in mind that we're largely a room of psychoanalysts or psychotherapists with a preoccupation with therapeutic alliance, the relationship, the reality of the vast majority of, the reality of a significant proportion of people who might be presenting for this kind of treatment with, say, a diagnosis like depression would be that they may have had some therapy. It in many cases will probably be the evidence-based more cognitive behavioral approaches. So whilst we're very interested in this, I think the reality of, well, regulatory agencies, for instance, they have shown their, well, certainly one regulatory agency has shown their naivety around the importance of the relationship. And to illustrate that, it was the FDA, I think, and they pointed to how the nature of the research is being corrupted by the same therapist being at different stages of the therapeutic journey. Whereas for us, we would see this as completely essential and a given of the importance. Their interest is more in what bias might creep in. There is more and more data coming in from the set of participants going into research trials, so that is starting to tease out, I would hope, going forwards, for instance, maybe what kind of attachment style they might have, ways of relating that we can kind of empirically capture. My hope is there will be more and more of that. To come to your effing the ineffable, that makes me think of how in research trials we have a very limited period of time where we're working with them, and then that's the end. Endings sometimes I don't think are thought about well enough in these trials. We obviously strike up very intense, there's a very intense transference, there's a very intense relationship, and then many of these participants are going back to other systems of care. In the UK, that might be the NHS, where they might not get seen for a few months. So huge contrast in the experience of care. But it does make me think about how in a protracted psychotherapy, part of the work might be the lightness of approach, the lightness of touch, in trying to pin down meaning or pin down any certainty over what an experience might mean or what their narrative could be. There's it's sort of an intensity of curiosity, not pinning things down, which trials, I guess, are conspiring to do, to tidy things up a little bit, as opposed to it being an ongoing process over months, years.
Thank you, Leonardo. I think that, well, I understand that the topic of this meeting is very provocative, and I take it this way. But I have actually two questions. One is that I understand that the use of psychedelics basically is a cathartic method, and I wonder if this is really applicable in psychoanalysis, since we know that the emergency of a sudden, abrupt subconscious material could be dangerous, and especially if the patient's ego is not ready to accept it. So the reason why psychoanalysis actually lasts for a long time is just because we want first have the ego ready to accept something that comes from the subconscious. And instead with the psychedelics, this could happen in minutes, and that could be, in my opinion, a large avenue to psychotic feelings and experience. But I have a second question about which I argue quite strongly against the dismissal of the evidence-based medicine for two reasons. One, because evidence-based medicine was not a kind of a weird creation of scientists, but has been carried out thinking of the protection of patients who might receive useless and dangerous treatments. But it's also extremely important to protect the therapists, because if I know that I'm using something based on some evidence, I will be also legally protected from the adverse effects and the dangers on the patients. So certainly I will not agree with your slide when you mentioned that evidence-based medicine is something that should not be considered. Thank you.
Just a moment, because we have a lot of questions there, so maybe we can harvest the questions and then you go through this, okay? Because we have a lot of people there, so.
So thank you very much, both So I have just few comments, and let's see if you can tell me something more. So thanks, Francesco. Thanks, John. What I appreciate the most is that finally we see the relevance of the intrapsychic and not only the intrapsychic in both presentation. So the context, the therapist, the world is very, very important. So just want to remind us, all of us, that the self comes from the other. So the structure of the brain, the organization of the brain comes from the capacity of the caregiver to allostatically regulate our homeostasis. So that's just a reminder for all of us, because I think that in science, our vantage point represents our epistemological foundation on how we proceed in our scientific research. So that's just my first comment. And a few words resonate with me: synchronization, desynchronization, that it goes with dissociation for me, because dissociation is a disconnection. And altered states of psychedelics are a kind of disconnection and reconnection. So they're moving towards a kind of topographical reorganization of the brain system, of how the brain represents itself. So that's what and with Georg Nordhoff, we are working on these models, and we have a model for dreams, for example, that is a topographical reorganization model of dreams, that it really goes also with meditation, and probably will have some parallelism with psychedelic and psilocybin. And another thing that I really appreciate is...
We have a lot of questions, Andrea.
Yes, sorry.
There are a lot of people there.
Simple things. So, to John. John, how do you... So, I really appreciate the early traumatic experience, attention on that. We know that it goes with dissociation. So, in your research, in your RCT or your other research, did you account for that, for the dissociative processing first? Second, you mentioned that also the future research are going to explore the use of psychedelics on PTSD. And my curiosity is, do you account for the differences in PTSD? Because we have PTSD with and without dissociation, according to the DSM-5 and Ruth Lanius findings. And then there is another diagnostic criteria, that is the complex PTSD. That it's very, very important, and it goes for us as a psychoanalyst. It's very important because it gives back the importance of cumulative traumatic experience, according to Masood Khan and all our stuff. Thanks.
So shift the microphone close to you. Was there no? Yeah. Okay.
No. So you have talked about the centrality and importance of music during sessions. Have you ever thought about bridging pictorial art therapy and psychedelics? And the other question is regarding the neurobiological aspects. You have briefly touched upon neuroplasticity. Could you say something about psychedelic-related neurotoxicity? Thank you.
Then you?
Okay, it's about the fact that here in Italy, at the moment, we can administer esketamine, only esketamine for treatment-resistant depression. And if you read the drug leaflet, you only read that you have only to control medical aspects, okay? And there is nothing about the problems, the matter you have treated today. And I see this as a risk because there is no attention on any psychotherapeutic process, because esketamine can be prescribed only by psychiatrists, that's okay, but there is no indications about the care you have to treat the context of administration. So I would like to hear your opinion about this.
Okay, the last one there, the last round there. So when we stop, and so we need time to answer, and the afternoon maybe Jeffrey can answer to these questions too, okay?
Hello, thank you for your conferences. John, you alerted for the dangers of non-prepared therapists to treat psychedelic states. And I wanted to question about the dangers of the generalization of the psychedelic usage. Like, for example, in two ways. Like, for example, retreats. So I want to experience different things. I'll go to a retreat, or a non-clinical retreat, or in a society that wants everything very fast. So I am in a pain, so I'm going to have a very fast treatment. So I'm a psychoanalyst, and someone talked about language, and language is very important in psychoanalysis. So transference creates the emotional states, and then is putting it into words that is transformative. So I believe, as a psychoanalyst, and this is why I'm interested in psychedelic clinic, I believe that when trauma is pre-verbal, that is very difficult to put it in words in the psychoanalytical relationship. And I believe that it might create like a different state of mind, create a dream that the patient cannot dream in a normal clinical relationship. But I just have this question about, all the dangers that might be linked to it. Thank you.
Okay, maybe we go on for 5 minutes more. Okay, you start. Okay.
I might just cherry pick some of the questions within the questions, if that's okay, because there was quite a lot there. To address the question around evidence-based medicine, I suppose my approach is pragmatic. This is the culture we're working in now. Particular types of scientific knowledge are prioritized, maybe reified. I don't doubt the value of evidence-based medicine in unpicking the potential for harms, for treatments that might not be effective. Inevitably, I think the process, for instance, of randomized controlled trials, that evidence being more exclusively used, it detracts from the complexity, from the just a lot of information that we need to hold in mind when giving these treatments. But to point to one thing, if the regulatory agencies could find models of capturing data over the longer term, so more ecological data harvesting, that would actually be much better at picking up more of the risks, the adverse events, because the trial timelines are so condensed. So I hope I've not come across as being too dismissive of evidence-based medicine, but I think just thoughtfulness is needed around what knowledge is produced and the limits of it. Your question around to what degree we're taking into account dissociative processes in various types of psychopathology. I think one model which I find quite helpful to think about is sort of the multiplicity of self-states that we all have and the relationship between these different self-states. I think myself and other clinicians, we like to think that psychedelics, given in the right context, can allow greater communication, more of a connection between these different self-states. So it is working just on principle at reducing those dissociative processes. I've not worked in a PTSD trial with psilocybin. That work is ongoing. When you go towards the more, I guess, relationally informed trauma in complex PTSD, I will be fascinated to see how that goes, what kind of therapeutic container they're using, and the length of, well, the nature of the therapeutic input going in, because it's obviously going to need to be very different if we're sort of tipping into more kind of borderline structures within the psyche. Yeah, the esketamine model is a very pharmacological one. I don't have any experience of using it. A researcher who's very good at unpicking, well, some of the flaws in the data is Mark Horowitz, and does point to how there are possibly quite a lot more risks around the use of esketamine as it's licensed. Yeah, dangers of generalized usage. It's difficult to comment in any way categorically about, well, the hypothetical future. It will be a future. People are using psychedelics more. I suppose if I'm a little bit more cynical about some of the data which can be which can suggest that psychedelic usage is associated with better mental health, I think the kinds of people who are answering those kinds of questionnaires are the people who are benefiting. I think there's inherent bias in some of that research. I think you were pointing to some of the dangers of the experiences that people can come back with, and one worry I have is if therapists aren't trained to work or to be able to consider what might be literal versus symbolic in people's experiences, and the memory wars could well be reignited. Hopefully not kind of full-blown memory wars, sort of 80s, 90s, false memory syndrome, but this kind of phenomenon is featuring in clinical trials, working very delicately with memories that participants have of very early aversive environments, and it's working very delicately with that and just staying with the pain of the uncertainty.
Yes, I would like to reply to these neurotoxic questions. According to the data I know, as far as I know, the classic psychedelics are quite safe. And maybe the toxic effects are more on the cardiovascular system, especially for the thought. And we have much more problems eventually with the non-classics. Just to quote one, they could affect the acetylcholine system and the memory system, especially the scopolamine, and that's why it also is no more. You can find scopolamine at the moment into the drug pharmacy, for example, for these side effects, I would say. Also because they actually binds with many other neurotransmitters, so the probability of affecting the neurosystem, of course, is larger. Okay.
So we are going to conclude, okay? Okay, yeah, it's time to stop this Friday sessions, and I would like to give you an anecdote. Okay, when about a year ago, we launched this topic. A colleague, a psychoanalyst, okay, a colleague wrote to me this: oh my God, we spent 800 years to go over the consciousness, introducing the unconscious. And now you are proposing to go back to suggestion and hypnosis. I don't come. So I would like to say to these colleagues, today I think we highlighted the importance of the consciousness, and we need to study and to know more about the consciousness itself. Thank you very much. See you at 2:30.